Okay, good morning. Thank you for coming. My name is Tim Smith. I'm from Portland, Oregon, in the United States of America. And today I'd like to talk to you about how the field of outcomes research, which I've participated in for probably 20 years now or so, has evolved over that time and perhaps even where we're headed into the future. These are many of my colleagues from across the states and across the world who've assisted me on this work over the past couple of decades, so I give them great credit. Many of these folks have very significantly contributed to the work that I will present today. I have no industry conflicts or disclosures to make. I think the primary disclosure is that I, like many of you, am a sinus surgeon, and I view these data through that lens, and we should probably keep that in mind. And most of the studies that I'll show today have been funded by the National Institutes of Health in the United States. So the early outcomes, this is really phase one. This is the beginning of outcomes research in the field of endoscopic sinus surgery, and it started just after the introduction of this technology to the world, really in the mid-1980s, and the first reports were case series by some of the prominent pioneers in this field. Here, a very young, that's David Kennedy, a very young David Kennedy is lecturing on outcomes to an audience that includes a very young Professor Stamberger who appears to be snoozing. And then came the 1990s and what I refer to as the quality of life outcomes revolution. This is when we saw, for the first time really, patient-reported quality of life using validated disease-specific instruments. These have proliferated over the years, but still we have various versions of the sinonasal outcomes test, the Rhinosinusitis Disability Index. And for the first time, we saw prospective data collection and calculations of what we call mean cohort data, which are really represented by the upper line here. This is several hundred patients accumulated into a very clean line showing improvement in quality of life and then sustained improvement after endoscopic sinus surgery. But if we break that single line down into all of the patients that make up that line, a spaghetti plot, you can see that most of the patients actually follow that trend. They have an improvement and a sustained improvement. But how would you like to be this particular patient who actually got worse after endoscopic sinus surgery? So we have to keep in mind that the means we report in research are not necessarily reflective of the entire population, and we should probably understand and study these outliers. Also, during this revolution in outcomes research, we started to ask the question, are we interested in the ultimate quality of life that's achieved or the change in quality of life that occurs with an intervention? And this was probably best demonstrated by patients with comorbid depression. Now you can see that patients who do not suffer comorbid depression ultimately achieve the highest level of quality of life. In fact, patients with depression, even with their improvement, don't begin to achieve the baseline of patients without depression. But if you look at the delta, the change in quality of life, it's very similar in these two groups. Well, this was very important to us because initially we saw the much higher ultimate quality of life in non-depressed patients, and we assumed that depressed patients were poor candidates for sinus surgery. But when you look at the change or improvement in quality of life, you can see, again, those are quite similar, and this led us to believe that was really the primary or important metric that we were interested in. Also, during this revolution, we faced a dilemma that still bothers us, honestly, to this day, and that is the lack of association between how the patient tells us they are feeling and what we see on our clinical studies like CT and endoscopy. As it turns out, what patients experience and what we see on our clinical tests really don't relate very well. And in this compilation of studies through this time period, as folks tried to sort this out, you can see very low correlation coefficients. So if these two things, the CT scan and the patient's quality of life, correlated perfectly, these values would be 1.0. But instead, they're all quite low, indicating that, again, what the patient experiences and what we measure with our clinical tests really don't correlate much at all, very minimally. And so it was important for us to understand that clinical tests and patient-based quality of life instruments, they're often measuring different aspects of the disease. And sometimes those things are related and sometimes they're not, but they're very seldom equivalent. If they were equivalent, we would really have no need to perform nasal endoscopy in our clinics. We could just ask the patients how they're feeling and proceed with that information. But we know that both of these measures or outcomes are important to us. When a patient comes to our office, we basically want to know two things. Number one, how do they feel? And number two, what is the status of their ethmoid mucosa? And we use those two factors to drive most of our decision-making with regard to their ongoing care. So both of these outcomes are important to our treatment decision-making. Around the turn of the century, we saw a movement from single institution studies to multi-institutional cohorts that reported on much larger numbers of patients. And we began to struggle for the first time with the concept of the difference between statistically significant improvement relative to clinically significant improvement. And so here you can see on one of the graphs from one of our early papers that all of these various phenotypes of chronic rhinosinusitis, those with aspirin intolerance, smokers, male, patients with prior surgery, they all experience statistically significant improvement as a group in quality of life following sinus surgery. But is that improvement meaningful to the patient? It reaches our statistical barrier, but does it mean anything to the patient? And so we asked, what is a minimal clinically important difference? And you'll see this MCID has entered the lexicon in recent years as we report our outcomes. And we found that when we defined the minimal clinically important difference and we compared those results to the early success rates from retrospective series, that compared to those 90 and 95% success rates, it's really that about 70 to 75% of patients experience clinically significant improvement in disease-specific quality of life. And so this helped us to sort out our primary outcome and the threshold of outcome to determine success. And once we've defined that primary outcome, we can use that along with a host of other factors. You're not meant to read these, just know that there are a lot of patient factors that come together. And if we can understand and incorporate those patient factors, we can start to break this disease down into multiple rarer diseases. Let's call them clusters here. And once we understand the clustering, we can then begin to treat the patients with a more precision approach, and we enter the era of personalized medicine. That's another lecture for another day, but you can see how understanding outcomes is important to that process as well. So meanwhile, while we were doing all of this work, around 2006, the first Cochrane review on endoscopic sinus surgery was published, and it concluded that endoscopic sinus surgery does not confer additional benefit to that obtained by medical treatment. Now, these conclusions were drawn based on 3 studies, 3 randomized controlled trials that were available. It disregards all the observational literature and other studies that were done. And importantly, none of these studies compared surgery to medical therapy in patients who had failed what any of us would consider a substantial trial of initial medical therapy. So the results, these were randomized controlled trials, but the results of these trials were really not applicable to our everyday practices. And so this ushered in the era of incorporating comparison groups into our studies, and we're seeing more and more of this in recent years. We needed better data that was actually generalizable to the patients that we treat. And so we asked ourselves, well, what about the patients who have failed medical management? What we would consider appropriate and substantial medical management. What happens to them? We know that some of them elect to have surgery, but some actually elect to simply continue with their medical therapy. And there's a lot of selection bias built into that, but we decided to follow these patients over time to understand what happened to them. And so we enrolled patients who failed a minimum trial of 3 weeks of culture-directed or broad-spectrum antibiotics and topical steroid therapy. And honestly, about 95% of these patients also failed a burst of oral steroid. And we found that at the conclusion of those therapies, if the patient continued to be symptomatic, they were considered surgical candidates. Of those patients, about half of them chose to continue medical therapy, and about half chose to move towards endoscopic sinus surgery. And very surprising to us, those 2 groups, the ones who chose medical therapy, the ones who chose surgery, had similar CT staging or scoring at that baseline measure. We were convinced that the patients with greater disease on the CT scan would choose surgery, because after all, they have more severe disease, and those with lesser disease would choose ongoing medical therapy. But not so. As it turns out, the patients don't care what their CT scan looks like. What drove their decision-making was their quality of life. And we found significantly more quality of life improvement in the surgical cohort compared to the medical cohort. And we found significant reductions in antibiotics, systemic steroid use, and missed school and work days in the surgical cohort. And as we followed these patients over the course of a year, we found that about 1/3 of the patients who initially elected medical therapy crossed over to surgery at some point during that year. And what drove that decision-making process? Once again, it turns out it was quality of life. So let's look at these 3 groups and how they behave. The solid line are patients who initially elected medical therapy. You can see they start with a higher quality of life relative to the patients who elected surgery, and they have some improvement in their quality of life, though they don't improve to the level that patients who initially elected surgery improve. The surgical cohort starts with the lowest or the least quality of life, and they end up with the greatest quality of life. They certainly had the greatest change with their intervention. The dotted line here are the crossover patients. They experienced an initial worsening in quality of life that evidently drove their decision-making towards surgery, and then they improved their quality of life over the subsequent months, although they didn't improve to the level that the patients improved who initially elected surgical management. And this has opened up an entire field of appropriate timing of sinus surgery that Claire Hopkins and others have led, and their early results suggest that perhaps we should be considering operating earlier than late. My group, using some data, are in the process of publishing a paper that found the exact opposite results of what Claire Hopkins found. So I'm not convinced on those data. I think our paper will not convince you either. There's still a lot of work to be done to understand appropriate timing of sinus surgery, but it's a fascinating field of research in and of itself. So despite all of this work, these are challenges that we face in the United States, where we have many different payers with many different policies regarding procedures and therapies that they will cover and not cover. Despite all of this work, a very major third-party payer in the United States has recently drafted a policy calling endoscopic sinus surgery investigational and experimental. So this is very powerful language, and if you're in the United States practicing, the translation is, we will not cover the costs of endoscopic sinus surgery for these patients because it's an experimental therapy. And they've stated this because of a lack of randomized controlled trials. And so thankfully, we at least have some fairly good observational data to refute this. This is one of my favorite Zen teaching, is the main thing is to keep the main thing the main thing. And in the realm of chronic rhinosinusitis, it appears that quality of life, that's primarily what we're treating and trying to improve. And that is, in fact, the main thing. But it's not the only thing. And there are other important outcomes and measures that we should examine. And I find that one of the most fascinating is in this realm of econometrics, which are really critical to health policy decision making. And I'd like to talk to you about three things: health state utility, QALYs, or quality adjusted life years, and then cost effectiveness. Let's start with health state utility. This is a value between 0 and 1 that each of us in the room can place a numeric value on the value of our current quality of life, our current state of health. Okay? 0 is death, and 1.0 is perfect health. And if you measure this in the United States, we find that the mean health utility value is 0.81. And if we look at patients who have chronic rhinosinusitis, it's substantially lower health utility at 0.65. Now, this is in the realm of Parkinson's disease, moderate asthma, and end-stage renal disease with hemodialysis. So the important thing about health utility is it allows us to compare the disease we treat and the suffering in that disease to other diseases, and it helps put these diseases in perspective. It's amazing how patients with chronic rhinosinusitis perceive their disability and their disease process. It's also amazing how, as clinicians, we project our own expectations onto patients with regard to how much they're allowed to suffer based on the disease that they have. Now, perhaps more interesting than baseline health utility, we can also measure changes or improvement in health utility based on interventions. And then we can compare interventions across the disease spectrum. So a minimal clinically important improvement or difference in health utility is 0.03. Primary endoscopic sinus surgery improves health utility by 3 times that value. Revision endoscopic sinus surgery improves health utility by twice that value. Now, this is in the range of total joint replacement surgery and coronary angioplasty. And perhaps even more interesting than that, with surgery and ongoing medical therapy, we can return health state utility to the normal values of the population. It's very, very powerful information. At least in the United States, these are the types of therapies that our society wants to invest in, those that return health state utility to normal levels. Now, we can convert health state utility into quality adjusted life years as a primary outcome, and then we can perform a cost-effective analysis using an appropriate time frame, and that's critical, an appropriate time frame for comparing therapies. And what we found in our studies is that the average patient at enrollment is about 45 years of age. So they're likely going to suffer this chronic disease process for 3 decades, 4 decades. So we use a time horizon in these cost-effectiveness studies of 30 years. A number of assumptions are made, and in the end, what we found is that in US dollars, endoscopic sinus surgery costs about $26,000 to produce 22 quality adjusted life years, and medical therapy costs $42,000 over the lifetime of the patient, or over the 30-year horizon, to produce about 19 quality. So more expensive to produce fewer quality adjusted life years. And when you do a sensitivity analysis, there's a 95% certainty that endoscopic sinus surgery is the more cost-effective choice. And again, I think the most important thing here is the time horizon. Yes, surgery is expensive in the very near term. In the short term, it's very expensive. When you look at these and play these therapies out over decades, then that calculation can change. We're not very good at that, at least in the United States. We tend to make decisions based on costs that are occurring this year or next year, not 30 years from now. So now we enter really a new phase, and that is quality management. And a health policy advocate in the United States, very well known, has said that the biggest issue facing the American healthcare system is our inability to improve. And so I'll ask you the question, do you consider yourself a high quality provider? In the United States, payers are defining high quality provider, and they're categorizing us, and then they're applying patient incentives. Let me give you an example. For one major payer, they define a high-quality otolaryngologist as a clinician who performs 1 or fewer nasal endoscopy procedures per patient with chronic rhinosinusitis per year. A low-quality provider performs more than 1 nasal endoscopy per patient per year. If you'd like to see a high-quality provider, your copay, what's due when you check into the office, is $20. If you want to see a low-quality provider, your copay is $100. So we in the United States are frustrated and asking ourselves, well, how can they do this? How can they just be so capricious about these definitions? But we, in fact, have not defined quality around the management of this disease process. And it gets back to that old argument that if we don't do it, others will do it for us, and they'll do it in a way that serves their agenda, very likely. So we really need to better define our health value proposition. Now, some of the initial studies in looking at quality of management look at geographic variations in various treatment modalities. And what we know in the United States is that per 1,000 people, about 1 in 1,000 gets endoscopic sinus surgery. And this is in the realm of spine surgery in the United States. So 1 in 1,000 across the board. But there's very significant geographic variation in that rate across the United States. So why is it that you're 3.5 times more likely to get sinus surgery if you live in South Dakota as compared to Vermont, where the rate is only 0.5 per 1,000? And there's really no good explanation for this other than practice variation that is explained by factors other than what would ensure quality management. So, as we get to the next level of scrutiny, we begin to compare surgeons' outcomes. Well, there are several barriers that are in place preventing us from doing this. We've not really clearly defined the outcome or broadly collected the data, though we're getting better at that. At least in the United States, we're getting better at that. We've not developed a disease severity index. Remember, different practices have different patient populations. Some have different types of comorbidities, more challenging disease. I mean, we all think our clinic sees the most challenging patients, right? And everybody else sees the easy ones. So we have to find a way to level the playing field with a disease severity index so we can make fair, just comparisons across practice sites. We have to establish a time frame for outcome measurement. How long is long enough to follow these patients and to say that is when our ultimate outcome time frame shall be? All of these things are imperative to quality improvement. So the question is, are we going to go through these steps and do this, or are we going to let others do it for us? Well, first, how long is long enough? And we've looked at this question, a couple of different instruments here. One, the score goes up as the patient improves. The other, the score goes down as the patient improves. We found they stabilize at about 6 months, and they remain stable up to about 2 years, and these have continued out to 5 years for the most part. So it appears that quality of life measurement at 6 months post-op is a very reasonable time to measure your primary outcome. Next, we performed a blinded evaluation of 3 sites in our clinical research consortium, about 75 patients per site. Our primary outcome was the sinonasal outcomes test 22 at 6 months post-op, for the reasons I suggested. So think about that. Do you think there's a difference? 3 sites, academic tertiary care sites across the U.S., each contribute 75 patients for evaluation. Do you think there's a difference in the outcomes between those sites? I didn't think there would be, but there was. Here are the improvements in SNOT 22 score, -20, -27, and -29. So the worst performing site had about a 20-point change, and the best performing site had about a 30-point change. And remember, the minimal clinically important difference for the SNOT 22 is 9 points. So there is a clinically significant difference between these sites. And I remember my colleague, my research colleague, Jess Mace, came to me after he'd performed this analysis, and he was not very impressed. This wasn't a particularly sophisticated analysis. And I looked at him and I said, Jess, which surgeon do you want to do your sinus surgery? And he said, well, I want this 30 point. And I said, do you have any idea how powerful that statement, that information is? So the next thing we did is look at the differences in baseline comorbid conditions and factors for these patients. And what we found is that the worst performing site had a higher proportion of patients with corticosteroid dependent conditions. It wasn't necessarily corticosteroid, and I mean systemic corticosteroids, not topical. And it wasn't just chronic rhinosinusitis and asthma. There were other inflammatory diseases, arthritis and other diseases that required steroids. But the point is, if your patient population is high in patients who are dependent on corticosteroids, then your outcomes are likely to be worse after sinus surgery relative to other sites. The one that interested us the most was septoplasty, septal deviation. The worst performing site had the lowest proportion of patients with septal deviation, and they performed septoplasty less frequently, much less frequently than the other two sites. Now, when you account for those two variables in the model, then the differences in outcomes between the sites disappears. So we leveled the playing field by accounting for two variables here. We then went to Canada, where there's more of a single payer system and you can follow larger groups of patients here, but we didn't have the outcome, the primary outcome of quality of life at 6 months we were interested in. The outcome we had to use here was 5-year revision surgery rates, another interesting outcome, a suggestion that the prior surgery had failed. And the mean revision rate was almost 11% at 5 years. But there were outliers. There were surgeons who had much higher revision surgery rates than others. And again, 3 variables stepped out. Systemic corticosteroid use. If you had patients with systemic corticosteroid use were 1 1/3 times more likely to require revision surgery. Patients who underwent concurrent septoplasty were less likely to require revision sinus surgery, consistent with the data from the US. And of course, the presence of polyposis. If the patient has polyposis, they were 2 times more likely to require revision surgery. All of us would have guessed that. And then once we included these 3 things in the analysis, the differences between the surgeons disappeared, with the exception of 2 surgeons still fell out. So those would be the surgeons we would need to address in a true quality management system. So to summarize, the comparison of surgeon outcomes is feasible. I think it makes us all a little anxious, but it's certainly feasible. We need to develop a robust risk adjustment model so that we all feel this is fair. And that might include baseline quality of life, polyp status, systemic steroid requirements, and then septal deviation septoplasty. We need to study more community sites. The Canadian data I showed you looked across the country at multiple different sites. The data from the US really comes from tertiary research centers. So it's difficult to assume that we can generalize that to the rest of the population. We need to actually study community sites and understand them better. So engaging clinicians in quality improvement, at least this is our experience in the US. It's kind of like the stages of grief. You know, we start with denial. There's really not a problem. We don't need to look into this. And then we get some data on our own practices and we enter this angry phase where we're convinced these things are wrong. And then bargaining, we need different measures. We just haven't quite got the measures yet. And then depression, my patients are sicker. That's where our disease severity index comes in. And then finally, hopefully, we will get to acceptance, where we recognize that we really can do better. There's probably a lot of room for improvement on this front, and that we as clinicians, as physicians, need to drive this field forward rather than waiting for others to make these decisions and drive them towards us. So to summarize, I think we've come a long way in this field over the past couple of decades. And I think that disease-specific quality of life has clearly established itself as the primary outcome measure. It's not the only one, but it appears to be the primary one. It is quality of life, not CT severity, that drives patient decision-making in chronic rhinosinusitis. And I've argued that we as clinicians place far too much weight in what we see on a CT scan with regard to our treatment decision-making. Now, there's a fine line to walk here, and I'm not advocating that patients who are symptomatic with normal CT scans deserve surgery, but I'm saying that we have overemphasized what we believe that the CT scan can show us about the patient, and it's been proven over and over again, it really doesn't show us all that much. We know that 75% of patients, on average, will have clinically significant improvement with endoscopic sinus surgery, and that patients who have failed appropriate and substantial medical management, who elect endoscopic sinus surgery, will have larger quality of life gains. They'll see fewer antibiotic and oral steroid exposures in subsequent years than those who continue medical management. And if you play this out for 30 or 40 years, and the cumulative effects of those medications, particularly the steroids, then it starts to alter the cost effectiveness. Health utility gains are very robust and significant with endoscopic sinus surgery, and they compare to other important surgical procedures that are performed to improve patients' quality of life, like joint replacement surgery. Endoscopic sinus surgery and continued medical management is capable of returning health utility to normal values, normal population values. We know that endoscopic sinus surgery is a cost-effective option, again, if we look at the appropriate time horizon. And now we enter this era of quality management and value-based care, where it's really our outcomes, our individual surgeon outcomes. At least in the United States, this is the trend. It's those outcomes that we report that will determine our reimbursement or lack thereof with these surgical procedures. That's all I have this morning. This is a picture of my city, Portland, Oregon, in the northwestern United States. We have actually a tram that connects our upper campus up on a hill down to the city because there's a major freeway you can't see here because of the clouds, and very difficult to transport otherwise. So I think we're one of the very few medical campuses with a tram holds 100 people each way, and it goes every 2 minutes back and forth. And this is famous Mount Hood, one of the Cascade Mountains in the background. I hope you'll come visit me in Portland someday. That's all I have this morning. I'm certainly happy to take any questions from you. Thank you again for your attention.